Friends, the topic she is going to talk on is not so unimportant that it is towards the end of the session. It's very, 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 very important. This is a disease all of us, all the nephrologists all over the world see very often as a glomerular disease. And the disease affects people differently. Apart from the fact that it is treated differently, it also has probable different pathogenesis, different behavior, even untreated in its natural course in different races and in different countries. And Dr. Alexander has put her effort with her group during the last 3 to 4 years to see how it behaves in South Asia. We are not interested in her interest. We are interested in her suggestions from her research and her interest in behavior of the disease. We value her work a lot. It's an extremely scientific work, and as people attending a meeting of nephrologists, not just postgraduates, practicing nephrologists, I would like to know whether this 22-year-old college student who has got 300 milligram of protein to 600 milligram of protein varying at different times during the month, who underwent a kidney biopsy, who has IGA nephropathy, will get into terminal renal failure soon or will remain like this for a long time. Like that, all of you will have many questions. The basic idea of these meetings are to get answers to practicing nephrologists on these questions. So even if she goes on presenting a lot of data, slide by slide by slide by slide, it is also a request from me that she must give definite conclusions from these slides. So with this request, I also would like my co-chairman to say a few words about the lecture.
We come to the last session of the conference. So we have Dr.Suceena Alexander from CMC Vellore to talk on the IGA nephropathy in South Asia. Over to Suceena.
Good afternoon, everyone, and greetings from CMC Vellore. Thank you, sirs, for that very kind introduction, and I thank the organizing committee for giving me this privilege. So my talk here is on South Asian IGA nephropathy. This was also my PhD topic, and I am very thankful for all my mentors, teachers from my own institute and from other institutes who have helped me do this work. Before I delve into our own work and give some insights into what is different in South Asian IGA nephropathy, I would also like to tell you about the challenges that we face in this region, mainly because it is CKD is in epidemic proportions here. There's a very skewed doctor-to-patient ratio and a very different, there's no referral system. There's no prospective regional, national, or societal registries as of now. And there are a lot of practices other than allopathy that goes on, and no universal or targeted screening programs for kidney diseases. Now, many cohorts from many centers in India, including ours and from Chennai, way back in 1985, had shown that there was a severe presentation of IgA nephropathy among patients, and a significant number of them progressed, unlike what was reported in the literature. And this even led to coinage of an informal term called malignant IgA nephropathy. This was a recent retrospective cohort from a 4-center biopsy cohort by Dr. Swarnalatha Gaurishankar, which also showed that the prevalence of IgA nephropathy in the biopsy was about 13%. So what are the questions that we need to answer for our population? Is IgA nephropathy a different disease or the same disease with effect modifiers? Can the severity be fully attributed to only late presentation? What are the effect modifiers, if there are, in the pathobiology? Does South Asian ethnicity have a role in its manifestations and prognosis? Do tropical infections or low socioeconomic status influence IgA nephropathy? What is the trajectory that we see in our population of renal progression? And does immunosuppression have a role in limiting renal progression? Now, I don't have answers to all these questions. I'm just going to show you what data and what we have got from our work, and some of these questions are answered, but still there are many more unanswered questions that needs to be studied. Now, Grace nephropathy was the first prospective South Asian IGA cohort, which started early March 2015, and it completed a 3-year follow-up in September 2020, and the longitudinal follow-up is still ongoing with biosample collection. It represents mainly patients from South, Central, East, and Northeast regions of India, including the neighboring countries of Bangladesh, Nepal, and Bhutan. Now, when we looked at the presentation of these patients and categorized them according to the GFR at presentation, what we realized is that the median, the symptom that takes the longest till kidney biopsy is hypertension, but even that we had a median time of 10 months from the start of clinical symptom. Most other symptoms took a median time of about 3 to 4 months. Now, this does not mean it is only from the onset of clinical symptoms. So there is a huge population which is there, which has subclinical IgA nephropathy, and it reaches the clinician only when any of these symptoms develop. This also emphasizes that there is a need for at least a targeted screening, especially in newly diagnosed hypertensive patients, especially when they are less than 45 years, and when they are diagnosed as hypertension, there are many people do not do a urine routine or a serum creatinine. So many of them go undiagnosed for many years before a nephritis is recognized in them. Now, this is the same thing which is stratified according to eGFR as well as according to proteinuria. And here, if you can see the pink and the red, they are the ones which is hypertension and hypertension-related symptoms which predominated in our cohort. There was a significant proportion of people who were incidentally detected to have IgA nephropathy, and that is shown as a light green color. And if you look at the spread of the light green across the eGFR tertiles, it is almost equally spread. So it doesn't mean that incidentally detected IgA nephropathy patients are detected early. There are many people who are detected late incidentally. Macroscopic hematuria or visible hematuria was not very frequent in South Asian IgA nephropathy, but this is one of the most common symptoms worldwide. Another important presentation was even the hypertension was diagnosed only when the patients presented to the clinic with visual disturbance. So there is not even a program whereby we have a routine screening of blood pressure. And this emphasizes the need for simple screening tests. At least 34% of patients had nephrotic range proteinuria at presentation. In this cohort, the patients, 201 patients, were distributed equally between all the 3 eGFR tertiles. So we had equal representation in all the 3 tertiles of eGFR. When we looked at the correlation of clinical parameters with the MEST scoring, there was significant There was significant increase in proteinuria with MEST S1 score and decreased GFR. Also, there was significant correlation of MAP, proteinuria and eGFR with the MEST T score. Even people with incidentally detected mild IgAN, the so-called mild IgAN, had significant fibrotic lesions. Those people whom we consider as low risk, for example, doctor had said 600 milligram of proteinuria in a 22-year-old man. That was a question that he had posed in the introductory comment. What we found was even in people with more than 60 ml GFR and a 24-hour urine protein of less than 1 gram, 38% of them had a segmental lesion and 20% of them had a T1 or a T2 lesion, which means that even this cohort is not a benign cohort for us. And as expected, as the proteinuria increased to more than 3 grams, even in a well-preserved eGFR cohort, the proportion of segmental lesions and the proportion of tubular lesions, IPTA, increased. So this led us, this is just a hypothesis, which is an open question, as to whether is it the low nephron number which is causing this in South Asians, or is there a specific fibrotic response to mesangial IgA deposition in South Asians. Now this cohort was not a clinical trial by any way, it was just a prospective observational cohort, but according to our center's guideline, most of the patients all patients who had more than 1 gram of persistent proteinuria and eGFR less than 60 received a short course of steroids for 6 months. And the background therapy was optimized. The outcomes, if you see at 3 months, a composite outcome, which is defined as a more than 50% decline in eGFR or dialysis or transplant or death, happened in 37% of patients. And the eGFR decline of more than 5 ml was present per year was present in about 40% of patients. About 34% of patients achieved complete remission at the end of 3 years. When we looked at the standard international IgA risk score, so this was the risk score where the patients were arranged according to the ascending order of the risk. The ones in the red vertical bars are the ones that had composite outcome at the end of 3 years, and the green bars are the patients who did not have composite outcome at the end of 3 years. The median risk predicted by the international prediction equation was 18.2 for our population. But when we looked at the actual data of how many people had composite outcome at 3 years, people among the cohort which was less than 18, 9% progressed to composite outcome. Those who had more than 18 score, 54% of them progressed to composite outcome, which told us that the IgM risk predictions tool does underestimate the actual risk of South Asian IgA nephropathy. When we looked at the probability of survival based on eGFR, which is shown in the right side graph, the decline in eGFR of more than 5 ml per minute was associated with significant prediction of composite outcome. And it had a sensitivity of more than 89% and a specificity and an equal specificity for detecting composite outcome at 3 years. So this was a very significant, I could say, a clinical biomarker for our patients. That is, if you go by a eGFR slope after optimization of background therapy for the first 6 months, if you are following after patients, and if the eGFR slope of these patients fall by more than 5 ml per minute per year, the annualized decline, then they are at a very high risk of, this was a very strong predictor of progression in our cohort. This again is the cohort divided between the tertiles of eGFR and proteinuria, where the pink color are the patients who reached composite outcome, and the green color are the patients who did not reach composite outcome. Here again, for each eGFR tertile, as the proteinuria increased, the likelihood of rapid progression and composite outcome increased. When we looked at proteinuria in the various, the first KM survival graph, PR is partial remission and CR is complete remission. Partial remission and complete remission was significantly lower in the group that reached composite outcome. When you looked at sustained proteinuria, that is that last diagram in the bottom figure, this was the proteinuria over time. So you had at baseline 6 months, 1 year, 2 year, and 3 year for all patients. And the red ones are the ones who had composite outcome, and the green ones are the ones who did not have composite outcome. If you see at 6 months, both the groups had a decline in proteinuria with optimization of background therapy. But the only difference was the nadir of proteinuria at 6 months was different between the two groups. So at 6 months, the ones that had good outcome could achieve a proteinuria of less than 1.5 gram, whereas those who had a poor outcome could not achieve that nadir. So a sustained, the time taken to achieve proteinuria definitely was associated with composite outcome, and a sustained reduction of proteinuria to less than 1 gram at 6 months was associated with long-term renal survival. So the other take-home message here is to optimize the background therapy and to make sure that they have a sustained reduction of proteinuria to less than 1 gram per day. Now, when we looked at albumin again divided as those who had composite outcome and those who did not have composite outcome, there was significant lower serum albumin in those who did not have composite outcome, though this is not like a nephrotic syndrome where you have severe hypoalbuminemia. This is almost within the range, but within the range you will have relatively lower albumins. Now, insight into the pathobiology. We looked at secretory. I didn't go into the pathogenesis slides because of the want of time, so I've just straight gone into the experiments. Secretory IgA, there was a significant increase in secretory IgA in patients compared to healthy controls, but the secretory IgA did not associate with any clinical or histopath variables, nor did it associate with long-term outcomes. What about complements? Again, serum C3, there was a lower serum C3 in patients who had composite outcome, but it was not a significant predictor in the Cox proportional hazards model. The same with C4. C4 was a higher C4 in mainly because it was like an acute phase molecule, but again, no significant prediction in the hazards model. We also did not get any association of immunofluorescence C3 deposition with any of the clinical or longitudinal outcomes. Now, what about C4D and C3D staining? Again, though C4D, tissue C4D stain was increased in IgA nephropathy patients, it did not have any correlation with outcomes in the proportional hazards model. Now, coming to galactose deficient IgA1, which is regarded as the first hit in the 4-hit pathogenesis of IgA nephropathy. So this is a cohort from Ames where they had measured galactose deficient IgAN in 136 IgA nephropathy patients. It was a cross-sectional study, and they had found that serum galactose deficient level was higher in IgA nephropathy, but it did not correlate with any baseline variables and did not predict disease progression. For us, we also measured galactose deficient IgA1 in IgA nephropathy patients, disease controls and healthy controls. There was no difference in the level, no significant difference in the level, but there was a positive correlation of galactose deficient IgA1 with serum IgA levels. When we looked at the ratio of galactose deficient IgA1 to serum IgA, the ratio did, though it was not a diagnostic marker, it was a prognostic marker. That is, it was like a risk factor for those who had composite outcome. Other interesting thing that we also noticed, and it has also been reported in the literature, is that many of the patients who were on immunosuppression, there was a significant decline in galactose deficient IgA1 at 1 year. So galactose deficient IgA1 had significant correlation with serum IgA. It was not a diagnostic biomarker, but the ratio with serum IgA was a significant predictor for composite outcome in the Cox proportional hazards model. What about inflammatory biomarkers? Now, this was very interesting. We did a pilot testing of many inflammatory markers using the Luminex in our patients. And what we found was there was significantly increased inflammatory biomarkers like TNFR, CD27, CD30, and CD40. Serum April is another marker which has been touted as a biomarker for IgA nephropathy, and there are molecules that are in clinical trials, in various phases of clinical trials, which are monoclonals targeted against serum April or serum BAF. Now, what is its relationship in our cohort? This was done by Trivandrum Medical College, and it was presented in one of the, I think, European conference, if I'm not wrong. They had done a cross-sectional analysis of April and BAF in their population. And at the end of 1 year, they found that 31% of patients reached end-stage kidney disease had lower levels of April, but BAF was not significantly, statistically significant, but I don't think they had any correlation with longitudinal. It was just a cross-sectional study. Somebody in the audience, if they are there from this institute, can correct me. We measured serum April in healthy control, disease controls, and IgA nephropathy patients. And we correlated it with the MES score. So lower MES score was associated with mesangial proliferation and endocapillary proliferation, and a lower median serum April was associated with worse, that is with composite outcome. Though it was not a diagnostic marker, it did correlate with proliferative lesions, and lower median levels significantly associated with composite outcome at 3 years. Now, are there any ethnic differences in biomarkers? Why do you think South Asians are different? We still don't have any definite answers to this question, but we have seen some trends. Like this was a cohort which we compared along with our collaborators, and the secretory IgA, if you look at the secretory IgA levels, the Caucasian levels of secretory IgA, even in the healthy controls, are much higher than the Indian levels. And the Chinese levels are even lower. If you look at galactose deficient IgA1, again the same trend. The Caucasians have much more higher levels of galactose deficient IgA1 than Indians or Indians. But when you look at the inflammatory biomarkers, that had the opposite trend. Inflammatory biomarkers were much more higher in Indians rather than in Caucasian patients. And this was all across many inflammatory biomarkers. Before concluding, just a few treatment dilemmas that we still have in the South Asian region. This was a paper published by Ames in KI on optimal background therapy in high-risk patients. And they achieved partial remission in 55% of patients at 6 months. But they had to discontinue AC and ARBs due to intolerance in 20 patients. And our cohort, about 70% of them did receive immunosuppression based on our center's protocol. I have already told you about the outcomes, so I will not repeat it. What we found was, in the Cox proportional hazards model, it was the longitudinal variables that was more predictive of composite outcome than just baseline variables. So longitudinal variables was the slope of EGFR decline, serum albumin at 6 months, 24-hour urine protein at 6 months, and the biomarkers like galactose by serum IGA ratio, serum April, and MES-T2 score. So the message here is the first 6 months you have to give time to optimize background therapy. Any prognostication or any outcome will be more cohesive only when it is done 3 to 6 months down the line for an individual patient. Immunosuppression did have adverse event toxicities as well as infections. Because of the need of time, I'm not going into it. So our take on the hypothesis for South Asian IgA nephropathy is definitely the forehead pathogenesis, but most probably there are effect modifiers, probably the low nephron number, inflammation or occult GI infections, altered gut microbiome, limited access to healthcare, genetics and epigenetics. Now, is there a rationale for clinical trial in South Asian IgA nephropathy? Now, the low-dose testing trial has shown beneficial effects of steroid in the short term, but it has also shown that the effect wanes over time, and there is a need for effective longer-term agents. KDIGO also does not have specific recommendations for persistent proteinuria or impaired renal function in those who are at high risk of progression. Now, proteinuria and eGFR slope have been approved by FDA as validated surrogate end markers for approving clinical trials in nephrology. With this, by God's grace, we have secured the India Alliance Senior Fellowship, and we hope that we will be able to do this multi-center randomized embedded adaptive platform clinical trial in South Asian kidney biopsy IgA nephropathy. Many of you sitting in the audience are also collaborators in this trial. There are about 10 to 12 centers as of now in India, and about 4 to 5 are from South India. This will take off later this year. This is a MAMS platform trial. The advantage of this is that we can add on therapy as well as we can exclude therapies that are redundant based on the accumulating literature evidence. Thank you.
Thank you, Dr. Alexander. I'll quickly give you a little more information about what her group has been doing. I think they started in 2015, recruited patients till 2017. Am I right?
Yeah.
Okay. And started observing from 2017 and published in Kidney International Reports in 2020 of nearly 30 months of average observations. And the important thing I want all of you to take home is that hypertension must be identified. Ophthalmologists must be asked to check blood pressures, from what she said. And I would like her to repeat again. It is better that it comes from her self. What her advice to clinicians when they see IgA nephropathy. She asks us to wait for 6 months. Can you just repeat those few sentences you told us after you said optimize for the first 6 months? Can you tell us, Dr. Alexander, again?
Yeah, so I'll just illustrate that a little bit, elaborate that a little bit further. What I meant by waiting is not passive waiting, it is active waiting. So you are actually acting on the patient, but you are only waiting for starting any immunosuppressive therapy. So you need to be a little careful there, because in our population, we are seeing a lot of infection and toxicity. So we need to weigh the risk-benefit ratio. So your waiting is not a passive waiting at all. Now with a lot of background therapy that is coming in, you have RAS inhibitors, you also have SGLT2 now with all the DAPA and EMPA kidney evidence. Waiting is for optimization of blood pressure, optimization of your clinical parameters, and by 3 to 6 months, the risk factors that we have identified, if you have those in your patients, then they do come into a high-risk population where they may benefit from some kind of immunomodulating agent.
I will request the audience and my colleague to ask any questions, at least 3 to 4 questions. She deserves to be asked, even though it is too late.
Just as yes, Dr. Suceena, you have mentioned that the most important factor probably is the sustained reduction in proteinuria of over 6 months. So beyond that, when you again add, in addition to RAS blockade, SGLT2 inhibitors, and other proteinuria control measures, initially you may add on steroid and immunomodulatory drugs. So how long this will, how you cannot go endlessly giving this steroid to control the proteinuria?
Yeah, so that is an open question, because that is a rationale for the clinical trial that we are hoping to do. Because even in the low testing trial, it was shown that the proteinuria effect, the steroid effect on proteinuria wanes with time. So, and these patients are not going to stop proteinuria all of a sudden after giving steroid. It's going to go lifelong. So we do need a molecule which will have significant benefit but minimal toxicity that will go on for a long period. Whether that molecule is going to be hydroxychloroquine, or whether it is going to be anti-APRIL, or is it going to be the oral budesonide, that is an open question.
And as you have noticed, the galactose deficient IGA1 is, though it is implicated in the pathogenesis, but it is not the predictor of progression in the disease. But the ratio of galactose deficient IGA1 to serum IGA is one of the predictors for progression.
It looks like a risk factor, but we also require an external validation. This is a training cohort, right? This is just a single cohort. So obviously we will need to replicate this in an external cohort for it to be made a statement.
Okay.
Yeah. I have 2 questions. One is, since the international formula under predicted the outcomes, are you planning on revising formula for the South Asian?
We can have a formula which is specific for our population, and we are working on that.
Secondly, in your active control, rather active waiting period, would you now also consider adding finerenone because of its anti-fibrotic and anti-inflammatory and protein reducing effect?
Yeah, so I don't have evidence for it, but that is definitely one molecule we can study. So probably it will become one arm of the proposed MAMS trial.
Because it adds to SGLT2 inhibitor and RAS.
Anybody else? Dr. Alexander, before we conclude, can you tell us about the hypertension's effect once you were watching them? You told us about the fall in glomerular filtration rate. You told us about the proteinuria reduction. You told us about the serum protein. Then you told us about so many other things which we are not able to do day to day in the laboratory. And hypertension, we all think, is the one which can be easily controlled, as well as brings in a lot of damage in all glomerular diseases. Yeah. Have you noticed in your observations, hypertension control has any effect?
Definitely. It definitely has.
But
I actually had 2 slides.
I don't think you had a slide on it.
No, I had 2 slides which I deleted because the number of slides was more.
Don't mistake me. To a group of people who are not very intelligent, most important myself, I am the one who is not very intelligent, it is easy to follow things like hypertension, difficult to follow very complicated biomarkers.
No,
don't mistake me.
Optimization of blood pressure with background therapy is the backbone of treatment. So any other therapy is only after that.
Yeah. So your suggestions are control blood pressure and make sure whether you can reduce proteinuria and see whether you will not allow the creatinine clearance to come down, and also see that the protein in the blood remains normal. These are the most important things you have identified till now in your study.
Yes, sir.
When do you sort of plan to complete it and publish all the reports?
So this is an ongoing cohort. So
When,
it is,
when
it
in
is
another
just,
2 years, your
it is,
study
finished.
period was 5 years, isn't it?
it finished its 5th year follow-up last September. So we are still analyzing those data.
You think another 1 year it will take?
The clinical follow-up was meant for only 5 years, so the
Yeah.
clinical follow-up is over.
Good afternoon, ma'am. I'm Dr. Ronak from KMC. I just want to ask, what's the role of target release formulation budesonide in our population, and has it been done in our population, and is it being recommended with against steroids and its toxicity?
So I don't have, look, it has not been done specifically for South Asian IgA nephropathy. Only thing with this molecule is we have to watch out for GI related infections. So unless we do that with adequate sample, powered sample in our population, it's difficult to answer that.
But will you recommend it against steroids like oral steroids like prednisolone, methylprednisolone? Or
Based on the phase 3 trials, it has definitely shown benefit.
so in our population also will be using 16
Whether
mg?
that shows increased toxicity, I don't know. In terms of GI infection, that we need to see.
So as
Look,
of
all
now,
these trials are powered only for efficacy. They are not powered for toxicity parameters, and toxicity is different in different population. So whether it might be efficacious, but whether it has same or more toxicity than oral steroids, I don't know.
so as of now, it's like we can continue with steroids, or should we use, can try?
I don't know.
Okay, thank you.
I think, yeah.
From INU Bangalore, they have been using budesonide oral. The last year, I think they had
Pitta
presentation.
also has done
Yeah,
some
presentation
budesonide.
was there. Yes, they are using oral. They found
I
that
think
it is good.
Dr. Alexander will not be the best person to comment on it, isn't it, Dr. Alexander?
Yeah.
Yeah, okay. Now, with this, anybody wants to say anything about what we discussed? If it is not so, on behalf of my colleague and myself, I thank first all of you, and then the excellent speaker with the excellent, useful subject, and all the organizers. And this happens to be the last presentation event of the academic side. And now I will request my colleagues to take over. Thank you all.
Now I request the chairpersons to facilitate the speaker with a caricature. And this caricature was, the brain idea was from Dr. Gautam in honoring all the speakers with a caricature that is a miniature of the face. You all... Any delegate